Next, I call upon Dr. Monisha Mohan, consultant in pediatric ophthalmology in Strabismus, Ahlia Eye Foundation, Palakkad. She will be speaking on spectacles, contact lenses, and even more.
So thank you, Dr. Tanu, for including me in the IC and KSOS for the opportunity. So we have young children, very fast progressors, and very high myopia. And many parents don't want to wear, don't want to give them drops. So they ask us, what are the other options? So here we have glasses, contact lenses, and newer therapies with us. So coming to the myopia control glasses, so from 2018 onwards, we have had various myopia control glasses like the DIMS, and it is commercialized as Hoya MyoSmart. The Halt lenses, these are by the SLR group, and the Care is by the Zeiss MyoCare. And we have newer technologies and newer myopia control glasses such as DOT, that is by the single vision with the diffusion optics technology, and the Larry lenses, very recent one in 2024, where there are positive and negative lenslet array integrated spectacles. So let's look at them one by one. So coming to the DIMS lenses, so all of these lenses have a central clear area where it corrects for the distance vision, and then surrounding in the mid periphery there are about 400 multiple defocus segments which are 33 mm in diameter, and they are arranged in a honeycomb pattern, and each provides a plus 3.5 add which will control the myopic blur. Okay, so it converts the hyperopic defocus into a myopic defocus. Coming on to the Halt lenses, so this pushes the concept even further. So what happens is there is a shell of a myopic defocus that is created in front of the retina. So again, this has around 11 concentric rings and formed by 1021 contiguous aspherical lenslets. So in between you have the distance correction. So it creates a volume of myopic defocus. And coming to the Care, so these are cylindrical annular refractive elements. So here you have alternating defocus and correction zones in a ring-like pattern. So it again clears a blur effect as like a competing defocus, and that again causes a stop signal for progression of myopia. So here you can see that there are circular rings, and the ones that are elevated have a plus 3 lens, and in between you have the distance correction. So coming to the newer generation, so this is very interesting. So this is the DOTS lenses, so diffusion optic technology lenses. So here what you can see are these micro diffusers. Again, the central one corrects with the distance vision, and surrounding what you have are these micro diffusers. So these will reduce the contrast. Okay, so it is based on the contrast theory of myopia. And so just like how outdoors are helping for reducing myopia, similarly this is kind of incorporated into a lens, and this itself will reduce the contrast, and this will work while the child is still indoors. Okay, so this is the DOTS lenses and the Larry lenses. So here again you have a central clear aperture with alternating treatment zones. So here what is interesting is what they have found is you have positive and negative. So there is plus 3 and minus 3, and there has been a comparison between the two. So what they say is actually both of them reduce myopia, and there is no significant difference whether you're using a plus or a minus. So this is again, these are the Larry lenses. This is yet to be studied. The study has been started in 2024. Okay, so comparison between these lenses, that is the Hoya Smart, SLR, Zeiss, and Sight Vision. So all of them approximately they reduce, and the efficacy is about 60 to 70%. So the DIMS, Care, and the Halt lenses aim at reducing the hyperopic peripheral defocus, and the DOTS will reduce the abnormal contrast signaling in the myopic retina. There's also an asymmetric lens design where in the nasal retina you have plus 1.5, temporal there is 1.8, and inferior there is plus 2. The very little information about these. So coming to the Indian studies, they have compared the DIMS, Halt, and Care by the AIMS group. So here they have found that the DIMS and the Halt perform better than the Care spectacles. And Sandra ma'am and the group have done a study with regard to myocare lenses. So they did well compared to the single vision glasses. So if you see all of these, all of them did initially very well, and gradually the efficacy reduced. So this is probably because of neural adaptability in the retina as well, which is going on. So even the LDA, even the glasses, everything do initially very well, and gradually the efficacy kind of dims down. So these are the evidence-based insights. So presently DIMS and Halt are the best efficacious, and all the three designs are safe, well tolerated. So it's a non-invasive option, 50 to 70% efficacious, can be used between 6 to 14-year-old. It is safe, it is alternative to the other therapies. Again, cost is an issue, but actually when you look at the long term, when these children actually develop a high myopia and the cost regard with that, it's I think a win situation here. And again, they can have contrast issues and initial distortion, and they work better with lifestyle modifications together. Even though the power does not increase, if there is scratches and breakage that when the children are wearing, then again we'll have to replace them. So that is again of concern. The moment they have scratches, it reduces the efficacy. So coming to the contact lenses, so again there are contact lens designs. So one is the concentric ring design. The most famous one is the MySight, which is not available here, but it is the only FDA approved contact lens. So it works on the principle of stepwise myopic defocus. Then we have the progressive additional lens design. This creates a smooth gradient myopic defocus, like more plus to the less plus, and then the extended depth of focus, just like you have in the IOLs. So this is available in India, and it is branded as SEED, and it's the EDOF lens. So this is through aberrations. So definitely, like any other contact lens will do, it has given a better visual quality. It is ideal for active children who are into sports, and myopia control option definitely, because it is efficacious up to 40 to 60%, confidence and cosmetic boost, and it can also incorporate toric designs as well. And superior myopia control is observed with higher AD. More AD means more defocus, and concentric ring design is more efficacious than PAL. That is because it is more studied than the PAL, and the patients who actually wear, they should be adherent, whether it is the glasses or contact lenses. So if they are wearing it and they have good clarity and experience with it, then it works well. So coming to the talk of the town, orthokeratology is gaining so much popularity. So initially these lenses were available 25 years ago, but they were used as a tool where you could make the child glass free in the morning. But right now, and then when they started using it, they realized, okay, it is also slowing the axial length. So that's when the Ortho-K was introduced as a myopia control tool. So before the lens wear, what happens? So before the lens wear, it is normal. So after the moment you wear the lens, it kind of presses the cornea, flattens the cornea out. And then when you remove the contact lens in the morning, it takes some time to come back. So that is when they are spectacle free. So this is how the Ortho-K works. So when the child applies the contact lens, there are 4 curves that is produced. So this is the center part, that is the flat curve that corrects for the distance correction, and then there is a second curve. So that will act as that is what is controlling the myopia. So when the cornea is pressed, the lens epithelial cells kind of is pushed away along with the tear film reservoir which is present in this area. So this will act as a tool to control myopia. And after that is the alignment zones. Alignment zone makes sure the lens is stable and centered. And the last one is the peripheral lift edge, and that area kind of lets the oxygen to the tear film and the oxygen to be permeable. So this is how the modern Ortho-K lenses are designed. And there are better designs, and it's made of good materials, and also people are more aware of how to use it and how to dispense these lenses. So it's based on the reverse geometry lens design. Central base curve is flatter, and treatment zone. So there are smaller treatment zones, increases the defocus, but it comes with the cost of reduced contrast and visual quality. And the materials allow high oxygen permeability right now, and there is customization when it comes to astigmatism and toric in the peripheries, and also available for higher refractive errors. So it has a strong evidence, 30 to 60% reduction. Efficacy again tends to be stronger in the first 2 years, and then smaller treatment zone is now found to be better, and it can be combined with other therapies like atropine. So ideal candidate would be between 6 to 12 years and suitable up to -6 and -2 cylinder. And for people who don't want to wear contact lenses or glasses, and regular follow-up is very much necessary. You need a corneal topography to be done serially, and definitely cost. A pair would cost right now up to 40 to 50,000. And infrastructure and availability, the optometrists and the optometrists and ophthalmologists should be very experienced with the Ortho-K fitting. So coming to the newer advances, so we have the red light therapy. So this is based on the fact that increased light exposure can slow down the myopia, and here we have an artificial source. So a low intensity red light, about 650 nanometers, which is handheld or tabletop, and 3 minutes twice a day in the children. It is device based and parent and child friendly. So 60 to 70% reduction is seen, effective in both mild and high myopia. And definitely see the problem with this is the after images, which is present in less than 5% of children. But recently there was a publication in 2023 where there was a retinal damage after the use of red light therapy. So after that, somehow people are a little more this thing when talking about red light therapy, and this is most of the studies have been done in the Southeast Asian population and not in the Indian population. So very few pilot studies have been done here. So there is some more time, and again, rebound effects are a problem here. So apart from that, we have the optic nerve head stimulation with blue light therapy for myopia control, and also the ultraviolet rays light for myopia control. So if you can see in this chart, amongst everything that has been compared, the control glasses, the soft contact lens, ortho K, atropine, and if you see red light therapy in the first 1 year, it reduces axial length elongation the maximum. So this is done only for 1 year. We don't know what really happens beyond that. So Gigi madam was talking about pre-myopia. So actually DIMS and HALT can be given is what they say, but to a child who does not need glasses, you cannot ask them to wear glasses. So that is very debatable. And so there is also a relation between myopia and binocular vision anomalies. So Dr. Tanu was talking about how accommodation is associated with myopia. So right now, based on the NRA, PRA values, after doing all the binocular vision tests, we can kind of get to know how much of AD is actually required for the patient with myopia. And so this is with regard to myopia and binocular vision. So if there is a normal binocular parameters for the patient, you can use any of these. But if the patient is having poor versions, then contact lens with vision therapy is required. If there is a lag of accommodation, we can't be giving atropine because it causes further lag. So you'll have to give bifocals or progressives along with vision therapy exercises. If there is a high AC by ratio, you can give progressive bifocals or LDA. If there is an intermittent XT, you cannot give glasses, because for the glasses to work, your eyes has to be straight. So in that case, you'll have to give prisms with single vision and add an atropine or ortho K, and vision therapy has to be started. Again, for for your intermittent ETs, we can go ahead with progressives and vision therapy. So tear film biomarkers is being studied. Imagine picking a child with just testing the tear film and finding out if the TNF alpha and the ICAMs are elevated. So it helps us to pick up progression early, intervention early, and monitor therapies. So again, there are treatments based on choroidal thickness. So thinner choroid is associated with higher risk, and so even OCT-based risk stratification can come. So we know one size does not fit all, and see all these for the myopia control glasses also. This has ideally both the sides, the nasal and the peripheral temporal retina, is said to have the same kind of configuration. But in a few Indian studies, it is found that the nasal retina is more myopic than the temporal retina. So when that is the problem, we don't know whether these glasses, or we'll have to formulate our own kind of glasses which are suitable for our population. And in spite of doing any of these myopia, testing whether there is a hyperopic defocus, myopia control glasses still remain effective in about 80% of the patients. Early pre-myopia detection enables timely intervention, and we'll have to optimize designs considering the binocular vision and the retina profiles of the patient. And combination therapy is becoming a boom, because we can combine if the child is not, especially for the ones who are progressing despite monotherapy. Thank you.